That's a hard act to follow. Thank you so much. And I don't see a clicker, so I guess if you don't mind. It's great to be here. I will try to keep the energy up. And I have not done this for 40 years, but I have worked in a lot of settings, like with migrant farm workers and with homeless adults and with homebound older adults, and so come at this from that perspective. I want to also ground this in a case. I was a house calls nurse practitioner and saw how much people's home environment affected their ability to take care of their chronic conditions, and how much home environment can just swamp not just the ability to take care of them, but the need, as in Maslow's triangle. Mrs. B sat in that chair all day long. I'm sure many of you have seen someone like that. And she had the TV in front of her and a toilet right near her, and that's her first floor. And next slide, please. This was her closet, because in dining rooms there aren't closets, and that's where her bed was, and it's safety pinned together. She's got diabetes, congestive heart failure, high blood pressure, and terrible arthritis in her fingers. So she can't even really get it open, and in the prior slide she's essentially in a house coat, even though she knew she had visitors coming that day. Next slide, please. This is her floor after we fixed it. I'm about to tell you about a program where we do some medical care and home improvement. So we were able to repair her floor, but she had holes throughout her whole first floor. So you might even say she was safer sitting in the chair, but of course we know she's not, because she was so deconditioned. She couldn't stand long enough to prepare food. She did have food. Her grandson would bring food and fill her fridge, but she didn't have the strength and the ability to prepare it. Next slide. So based on clinical experience and on the ABLE program developed in Philadelphia by colleague Laura Gitlin, we developed Capable. It's a combination of a nurse, an OT, and a handyman. And it addresses the person and the house together at the same time. And a little bit of a flip from what other people have been talking about. In this model, the older adult is the expert, and it's not about their chronic conditions. It's what do they want to be able to do to age at home safely and independently. And so although the assessments are universal, we ask people the same questions about bathing and dressing and meaningful activity and managing their finances. The goals that they set are completely individual. I want to be able to get upstairs and sleep in my own bed so I don't have to sleep in the lazy boy chair. I want to be able to take a bath without a grandchild having to pull me up out of it. I want to be able to sit on my back porch so that I can listen to the birds. So the professionals involved are eliciting those goals and using their clinical judgment to help them come up with how you're going to address the pain or the depression to achieve those goals. But they're not our goals. And we've improved physical function, decreased depressive symptoms, and for the people who care about the money end, we've been decreasing hospitalization and nursing home admission, which of course also participants and their families care about as well. Next slide, please. It's a 4-month program. As I mentioned, the 3 disciplines. The handyman part is about $1,300 of a total $2,800 overall cost. I think there's another click on this. And I'm sorry, there's going to be a lot. I didn't know I wasn't going to be, yeah. So the whole thing's a little less than $3,000. Go ahead. I'm going to tell you a quick case, and then we can get on to some of the results and some of the barriers. I know we were advertised as talking about the barriers to scaling and the ground truth, so we'll get to that too. One of our first Capable cases, we had a CMS Innovation Center funding, was just nodding off on her first visit and sitting in a commode chair, and that was the only chair in her bedroom, and she had not been downstairs in 2 years. And she couldn't get out of bed herself, and her husband would lift her up out of the bed and kind of plunk her on this commode chair that was too narrow for her hips, and she sat there all day. And when we were doing the assessment, she had said she wanted to be part of the program, but it was very hard to see how she was going to really engage in this 10 visits over 4 months. And she wanted to be able to get downstairs to wash her hair in the kitchen sink. That was her goal, which I think is a powerful illustration. That wouldn't have been any of our goals. If we walked in, we wouldn't have said, you need to wash your hair in the kitchen sink. But that motivated her for strength, for independence. She had not actually had a full hair washing in the 2 years since she'd been downstairs. And imagine, I mean, probably most of us don't go more than two days or so. And so it took her 30 minutes to walk to the bathroom, which was at the end of the hall that first day. But over the goals she came up with, she wanted to be able to, I talked about washing her hair, she wanted to be able to go to the bathroom on her own. She wanted to be able to get out of the bed on her own. All of these were motivating her improvement. And what we were doing around those goals were strength and balance, pain, depression, all the kinds of things that as nurses and OTs, we might have gone in and said, you should decrease your pain and you should do this. But really the whole thing was organized and catalyzed by her coming up with these specific things she wanted to be able to do. And so the changes to her home and her environment were tiny. They were things like bed risers on the corner of her bed, which are less than $20, a firm grab bar for her to push herself up the bed, exercises that are based on Otago, that's evidence-based from New Zealand. She came up with the idea of putting little plastic deck chairs along the hallway so that she could just practice. We would just come once a month and she would practice in between the visits so that she would stand up and sit down. And then she might be done for the day in the first couple of days, but gradually she could walk that whole hall. She still has one chair at the top of her stairs because she doesn't have enough stamina to go all the way down the hall and then down the stairs. But you know, that's a good adaptation for her. And she had grandchildren who would come over and they would scamper upstairs and say hi to Grandma and then go back downstairs. Now that she can go downstairs and she's downstairs a lot, she's much more involved in the family. And a month after we finished Capable with her, her granddaughter called and said they were all going to Atlantic City. And her husband said he felt like he got his baby back. A funny detail to me is that we still couldn't get her a better chair for her bedroom. And so she wanted a commode. We got her a wider commode, which is just shows you, you know, it doesn't always work out the way you want it to. But there she was, much more independent and stronger. Next slide, please. Here's just an example. This wasn't her house, but a visual example of how much common sense there is behind ideas like this. Go ahead. So we've published in numerous places. These are results from the CMS Innovations trial. The green is showing you improvement, and that's in activity of daily living limitations, instrumental activity of daily living limitations, depressive symptoms, and home hazards. Next slide, please. And then the CMS evaluators published this paper showing that if you can see over towards the right under the Medicare expend, that $2,700 per quarter for 2 years, for 8 quarters, capable of saving, and it only costs the $2,800 one time to begin with. So it saves about 7 times what it costs based on that. And then next slide, please. We also published Medicaid, so the people we were working with were dually eligible, and so it was saving Maryland Medicaid, or overall Medicaid. Mostly that rust bar is the difference in hospitalizations. So we had assumed or hoped that we would decrease nursing home utilization, which we did, which is that blue bar at the bottom, and that actually by itself was enough to pay for Capable for the whole cohort. But because people are more likely to be hospitalized, there's more opportunity to prevent hospitalization. Go ahead. So we started in one place in Baltimore. It's now in 21, actually 22 as of recently. And our challenge, go ahead. So the challenges we have are blending the funding streams everyone's talked about with social services and healthcare. What do? Do you go from one side? Do you go from both sides? Which side's more efficient? Who's got the power? And so housing and health are usually separate. We have had some wonderful luck finding partners. We're hoping to work with the PACE program soon. The other trick, as everyone's talked about, is aligning the financial savings, that you have to have the right pocket spending the money to get the savings. And also, naively, I went into this thinking, well, if we just prove it saves what it costs, everyone will want to do it. But that's not how it works, because things, cost money to start. And but still, 7 to 10 times of saving is catching people's eyes in terms of how to do it. Plus, everyone likes a handyman. Everyone says, "Can I get that from my parents?" So, next slide, please. A couple things we've learned, because the model isn't just nursing and OT and a handyman. It's really this flipped model of working with the person's own motivation, their own interests, their own goals, and so you can't just say, "Okay, here, do it." it really takes a little bit of training. We've mastered how to train people, and we have a combination of online and through distance, but we're going to have to ramp it up to be more accessible throughout the year all the time, because as more and more people do it. So training for different approaches than what we learn in nursing school or OT school or medical school, where we're not the expert, where what we're doing is supporting what the person wants, isn't a completely simple thing. And then also we've learned, scaling is a different skill set than either providing or initial testing. And so we have to work with a range of people with different skills to be able to do that. Also, I've learned a lot of healthcare providers and systems will listen and they'll say, oh, we already do that. And I used to just walk away and say, oh, they already do that. And then eventually I thought of saying, what do you do? And then they'll say, oh, we ask someone what they care about, or oh, we have grab bars, or when there's a perception that people are doing really patient-centered care that is very thorough. So I've learned to carefully listen and then try to reframe what I said at the beginning. That might be all. Can you go forward? Yeah. So thank you. I'm very happy to be part of this discussion. I would love to take any questions.